In the next 25 or 30 minutes, I've been asked to help you think about some very common clinical problems, namely proteinuria, hematuria, and glomerular disease. So it may seem like some unrelated topics, and indeed each of these topics does need to be considered in isolation, but then of course they can often occur together. And my goal for the purpose of this talk is to give you a framework by which you can think about these processes and then integrate them in more complex patients with these abnormalities. It's always helpful to go back to the basic anatomy in terms of thinking about these problems, and I will walk you through that in the next couple of slides. Then we'll turn to proteinuria, both its definitions and measurement, and come back to this anatomy and think about mechanisms of proteinuria. I always find it easier to remember things if I can understand, at least at some level, why they may be happening. A few practical words about management, much of which you probably heard from Dr. Tucker in his talk on chronic kidney disease. Then we'll spend a few minutes on hematuria, and I will talk about non-renal origins of hematuria because it's a very important distinction in the primary care office and, of course, in the urology or nephrologist's office. And we'll go into a little bit of the evaluation. And then we'll tie it all together with some of the more complex kidney diseases, but at a level that I think will be appropriate for you to think about for the boards. So we're going to come back to this case at the end, and I'm going to walk through it quickly, but it sets the stage for some of the issues we're talking about. A 67-year-old gentleman with a 4-week history of anorexia, nausea, lassitude, and pedal edema, long-standing hypertension, well-controlled with lisinopril hydrochlorothiazide, type 2 diabetes for 5 years, controlled with diet, and recently, over the past few months, been treated with phenoprofen, a non-steroidal anti-inflammatory drug for osteoarthritis of the hip. His exam is notable for some hypertension and the edema. His urinalysis is notable for the 4+ protein, trace blood, a few red cells, and occasional granular casts. His serum creatinine is 1.0, and I'll just say with a normal estimated GFR, but he has 7.7 grams of proteinuria in that 24-hour collection, and his serum albumin is suppressed at 2.8 with normal serologies and a normal ultrasound. So the question I'd like you to ponder as we go through the rest of this talk is, what might be the cause of this gentleman's nephrotic-range proteinuria? And we'll come back to this at the very end of the discussion. Does he have diabetic nephropathy, amyloidosis, a systemic small vessel vasculitis, minimal change disease, or is this hypertensive kidney disease? So think about that, and we'll come back to it at the very end. So a very basic review of renal anatomy. We have our glomeruli cartooned here and shown in a normal human biopsy here, made up of open capillary loops through which filtration occurs into Bowman space, and then that ultrafiltrate gets processed through the tubules and ultimately becomes the urine. So proteinuria and hematuria can occur from either the vasculature, the arterioles, or even the larger vessels in some cases, from the microcirculation of the glomerulus, and proteinuria originating at the glomerulus is different and in both quantity and quality than proteinuria that may originate from the tubules. And we'll have a lot more to say about this as we dive into the discussion of proteinuria. Just another cartoon showing a glomerulus with capillary loops and podocytes. These are the cells that provide the main filtration barrier at the level of filtration, which is occurring across these glomerular basement membranes. Again, afferent and efferent arterial. This is a tubule cut in cross-section, and it's the macula densa where there's sensing of tubular flow and GFR. If you were to turn this on its side, the blood would be coming in here, and then filtration occurring across this glomerular basement membrane with urine forming into Bowman space, and then blood returning back to the circulation through the efferent limb. If we zoom in on these podocytes, and the reason I'm showing you this is that these cells are often the target of glomerular disease. Primary podocyte injury is often what leads to the development of nephrotic syndrome, heavy proteinuria, and there are these very elegant cells that live in Bowman space, again cartooned here, shown in a transmission electron micrograph here, And through this branching foot processes, they form what are called slit diaphragms, literally the spaces that make up the outer layer of the glomerular basement membrane. Endothelium here, with blood circulating in here, GBM here, and then the final barrier are the foot processes from these podocytes, and then just shown as cartooned here. So normally proteins are deflected back into the circulation, and as we know, with normal kidney function, there's very little, if any, proteinuria that we measure, and very little of it is of glomerular origin. Okay, so let's think about proteinuria in isolation, and at the end I will share with you sort of an algorithm that will summarize these different decision points. So first, some definitions. We can measure 24-hour collections, and they are still useful, but as you know, cumbersome and sometimes a bit burdensome for patients. And most nephrologists have now relied much more heavily on the random urine protein to creatinine ratio. And in the next couple of slides, I will share with you why that ratio works as well as it does. But by definition, 150 milligrams a day or less would be considered normal. Protein to creatinine ratio normally would be less than a ratio of about 0.2, and again, I'll show you why the ratio works, but 3.5 would be the cutoff. We can also use the microalbumin, and this is a much more sensitive test for detecting the presence of proteinuria. And I would encourage you to really use the microalbumin as an important co-marker for the presence of chronic kidney disease. I heard some of the questions at the end about patients with borderline GFR and whether or not they should be referred and whether or not they have chronic kidney disease. If they have abnormal protein excretion, they have intrinsic chronic kidney disease and need to be thought about more seriously than patients that do not have proteinuria. And again, the 24-hour collection can be used not so much on the albumin side, but on the ratio. Most of us are used to doing this for monitoring our diabetics. And the normal ratio being less than 30, microalbuminuria being defined as 30 to 300, and then overt proteinuria or macroalbuminuria at greater than 300. And now I'll show you why random urines are adequate. So if I were to sample your urine at various points throughout the day, the amount of the protein concentration, so the amount dissolved in that degree, in that amount of fluid, is really going to depend on whether we had been fasting overnight and then had more to drink, and it's going to cycle as we hydrate and dehydrate throughout the day. So depending upon when during the day you were to measure the urine protein, you're going to get a different concentration. But it just so happens that urine creatinine is excreted with the same effect on concentration. So since the curves are superimposable, the ratio actually will give you a relatively constant readout and indicator of the 24-hour protein excretion. And the reason the ratio can actually correlate to an estimated 24-hour collection is that it just so happens that normally an average size adult will put out about 1 gram of creatinine throughout the day. So essentially, this ratio will approximate the 24-hour collection. Very useful and valid for both the microalbumin and the total protein. A brief word that could show up on the boards about transient proteinuria. Often the dipstick, due to this concentration problem, is less sensitive. But there are situations where patients will have either transient or false positive proteinuria. So obviously we would repeat it, and this is a relatively common problem occurring in about 4% of males and 7% of normal females, and is much more common after vigorous exercise or any febrile illness. And even patients with an acute illness may have transient proteinuria. That does not necessarily imply the presence of chronic kidney disease. A brief word on orthostatic proteinuria. This is a benign condition where proteinuria is detected during ambulation or exercise, but is absent when patients are in a recumbent posture. So I put this in because it could be part of a question testing your knowledge about some of the more benign conditions that can cause proteinuria. Studies have shown that most of these, when they do go on to biopsy, are normal, and it's thought to occur from hemodynamic alteration, basically changes in renal perfusion, either with subtle or little in way of glomerular structural abnormalities. And you can diagnose it by actually just measuring the overnight urine collection and document the fact that the total proteinuria that you may have measured on a previous one is not present when patients are recumbent. Okay, so now what about patients with intrinsic renal disease? So patients with an abnormal sediment or low GFR or clearly persistent and elevated proteinuria. Again, it's useful to come back to the anatomy that we briefly reviewed and think about proteinuria originating from the glomeruli or from the tubules. And the glomerular proteinuria, most often due to defects in the podocyte, in diabetic or in direct podocyte injury, can lead to some isolated proteinuria. It can lead to heavy nephrotic-range proteinuria, as well as a mixed picture of what we would call nephritic syndrome, which is a combination of proteinuria, urinary abnormalities, and azotemia. And we'll come back and talk about that in a little more detail. Tubular proteinuria really occurs when tubules are damaged, and that's most commonly seen in chronic kidney disease, where there's inefficient reabsorption of some of the filtered protein. And then one very important caveat to keep in mind, which is that you can also get proteinuria by what's called so-called overflow. So this is abnormal amounts of protein, typically a paraprotein, that exceeds the tubule's ability to reabsorb, not necessarily because there's been damage to the tubules, but because there's so much being filtered that it cannot all be reabsorbed. And that's an important caveat and indicator that you may be dealing with a plasma cell dyscrasia. So what's nephrotic-range proteinuria? As mentioned previously, it's greater than 3.5 grams of protein per day, and it's predominantly albumin when you look at the nature of the protein in the urine. It's considered to be pathognomonic of glomerular disease, and is often associated with some other very important clinical findings, namely the presence of edema, which actually results more from sodium retention than from the hypoalbuminemia. Although in the case that I presented at the very beginning, that gentleman actually had both of these. You can see hyperlipidemia and a hypercoagulable state due to the urinary losses of normal regulatory proteins that are important for cholesterol metabolism and for the synthesis of protein S and protein C. And this can be quite dangerous in the nephrotic syndrome, leading to life-threatening hypercoagulability. Typically, nephrotic syndrome can occur from a primary process affecting the glomeruli, or we can see it as part of a systemic illness with secondary involvement of the glomeruli. The primary diseases, which I don't think you're going to be expected to know much about in terms of what the pathology looks like, can be summarized with this general list, and it falls into the category of focal segmental glomerulosclerosis, membranous nephropathy, minimal change disease. These are typically heavily proteinuric conditions. IgA nephropathy, as I'll show you later, can really fall into one of several categories, including a nephrotic picture, as can membranoproliferative glomerulonephritis and an entity called fibrillary glomerulonephritis, which again is due to some abnormal, often to paraproteins. And of course, we can see nephrotic-range proteinuria in a variety of very common diseases, the most important of which being diabetes. Less common amyloidosis. We can also see these pathologic patterns after a variety of infections, including hepatitis, both B and C, HIV disease, syphilis, schistosomiasis, as well as others. These renal lesions can also be seen in autoimmune diseases, such as systemic lupus or rheumatoid arthritis, and very commonly can be seen in association with a variety of drugs that are commonly used, particularly NSAIDs. We don't see much use of gold these days, but penicillamine is still used, and these patterns can be seen pretty much with any medication. This is put in just as a reminder, since diabetes is the major issue we all confront in most of our practice. It plots the general course of time frame of diabetes with the urine albumin to creatinine excretion ratio. And early in diabetes, there are structural changes, but microalbuminuria may or may not be present until about 3 to 5 years. Patients will then often progress to stage 3 kidney disease with microalbuminuria, and then, of course, as the disease progresses, end up with overt nephropathy and end-stage renal disease. Happens in about 40% of diabetics, and the presence of proteinuria, as you heard, correlates with the likelihood of chronic kidney disease progression. Just another word about tubular proteinuria and a brief word about the myeloma and overflow proteinuria. So typically, tubular proteinuria is less severe in terms of the amount, usually less than 1.5 grams per day, or a urine protein to creatinine ratio of less than 1.5. It's comprised mostly of normal proteins that are typically found in the tubule, Tam-Horsfall protein and beta-2 microglobulin. And as I mentioned previously, is really seen with chronic kidney disease and any cause of tubular injury. So hypertensive kidney disease, ischemic kidney disease, and really any form of advanced renal failure. We're not surprised if we see proteinuria in the 1 to 1.5 gram range. Again, as I mentioned, the filtered load being exceeded in overflow is very important to keep in mind, because your diagnosis and management of a patient with a plasma cell dyscrasia is, of course, going to be different. And this is an important pearl that could show up on the boards, and it's to remind you that the urine microalbumin test, by definition, but even the dipstick that's often used for screening patients, is only designed to detect albumin. So if you have a patient that has light chains in their urine, they may be dipstick negative in terms of proteinuria. And indeed, sometimes this is the way we'll actually pick up patients with myeloma, because they will have other reasons to measure urine protein. It will come back elevated, but their microalbumin or their dipstick will be negative, and then it's important to check an SPEP and a UPEP. I'm going to go quickly through the management, because I think you heard a lot about this from Dr. Tucker. So if they have a primary kidney disease, of course, we're going to treat it based on its pathology. We want to be aggressive with hypertension and the use of renin-angiotensin inhibitors with the goal of getting proteinuria to as low as possible. These patients do need to be sodium restricted as well because of the edema and the propensity to sodium retention. The hypercholesterolemia in a nephrotic patient can be quite profound and will often require additional medical management. And we target their LDL, as we do in most CKD patients, to an LDL of less than 100. And then, of course, we can control edema with diuretics as well. The use of RAS inhibitors, again, hopefully reviewed with Dr. Tucker in the chronic kidney disease talk, but there is a correlation between the degree of proteinuria and the rate of decline in renal function. And we like to titrate the RAS inhibitor up to the maximum dose tolerated in order to minimize the proteinuria. We do follow proteinuria as a surrogate endpoint. You often have to do other things in order to make room for maximizing these meds, both in terms of blood pressure control and sometimes in terms of potassium, and it requires adjustment of a variety of other medications that we can talk about in more detail with specific scenarios if needed. Okay, I'm going to switch gears, because proteinuria can occur in isolation as a primary kidney disease, or it can occur with hematuria. So I'm going to go through hematuria, and then we'll bring them together in the final part. So some definitions. How do we define hematuria? Defined as greater than 2 red blood cells per high-powered field. Gross hematuria will typically be seen as brown or red urine. If you spin the urine down and you pack down red cells, it will look red. But if you have a pigmented supernatant, you want to think about a heme-containing protein, such as myoglobin or free hemoglobin, as you might see in rhabdomyolysis or in an autoimmune hemolytic anemia. This is a big issue for all of us in terms of hematuria being very common, and a lot of it being of urologic origin. So I'm going to spend a moment or two giving you some clues as to why you may want to think renal versus urologic or vice versa. So if anyone has significant proteinuria, a ratio greater than 0.5, with hematuria, we really should worry about intrinsic renal disease, probably even before urologic disease, even though urologic disease is much more common. The abnormal UA is difficult unless you're used to looking at urines, and the hematuria that comes of renal origin looks different than that of urologic origin. And this is a slide of so-called dysmorphic red blood cells, where there's a lot of heterogeneity in the size of the red cells. They often have Mickey Mouse ears or appear like a snowman. And this occurs from the red cells crossing the basement membrane and being disrupted as they traverse through the tubule. And they look very different than blood that might originate from the bladder or from the urogenital system, where cells would look much more like what you might see on a smear. And then if you're lucky, you might see red blood cell casts. And of course, this is the sine qua non of an acute glomerulonephritis, but can also be seen in other processes. So for those patients where it's not so clear, there's no proteinuria, renal function's normal, we're going to think hard about urologic causes. And here are some of the common reasons why you might see hematuria: urinary tract infection, prostatitis, of course, menses, exercise, kidney stones. There is a pearl here in that if we see gross hematuria with clots, so urine that's actually clotting, it is virtually always urologic in origin. Renal bleeding or nephronal bleeding does not cause gross hematuria that clots. And that can be a very helpful historical physical exam feature to help direct subsequent workup. If hematuria is persistent or is gross, studies have shown that there is significant pathology in upwards of 10% of these patients, most of which will be urologic in origin. And of course, you're going to want to look for malignancy by looking at urine cytologies, imaging, and with the help of our urology colleagues, cystoscopy. Another sort of mild aside is that hypercalciuria, particularly in children, has been associated with hematuria. So in the younger population, the presence of hypercalciuria, even in the absence of kidney stones, has been associated with hematuria, and it's of a benign course. Now, if you have intrinsic renal disease, we can come back to our anatomy from the beginning of the discussion. You can get red blood cells in the urine, of course, from vasculitis of large arteries or catastrophes of large renal vessels through embolization or thrombosis or aneurysms or large vessel vasculitis. And then renal vein obstruction, either from tumor or from thrombosis, can also result in hematuria. Glomerulonephritis and vasculitis would be inflammation of the small vessels within the glomeruli, and can also be seen with hemolytic uremic syndrome, thrombotic thrombocytopenic purpura, disseminated intravascular coagulation, etc. And as I alluded to, you can see hematuria from tubular causes. So a tubular interstitial nephritis can certainly cause some hematuria. This is the picture of the normal tubules that I showed you, and you don't need to be a renal pathologist to know that this section of tubules is highly abnormal. And this is a dramatic example of an aggressive, an acute interstitial nephritis, not only causing kidney dysfunction, as you might expect, but also causing hematuria. There are a variety of things to keep in mind where you may see intrinsic renal causes of hematuria, but without significant proteinuria. And these tend to be in disorders of the glomerular basement membrane, so-called thin basement membrane disease, which can be seen as a genetic disorder where there is the presence of hematuria but little or no proteinuria. Alport syndrome, and then IgA nephropathy, as I mentioned, has a very wide spectrum from acute renal injury with little proteinuria to more of a pure nephrotic range type picture. And in these patients, there's often gross hematuria after some sort of mucosal stress, an upper respiratory infection or a GI illness. So now I want to connect, so you can think about proteinuria and hematuria together or in isolation, and there are going to be clinical scenarios where those are going to occur. In the case of patients with glomerulonephritis, we've already hit on the major points, but we want to first distinguish whether they have nephrotic-range proteinuria, and whether that's in isolation or with other abnormalities. The nephritic syndrome is actually a more worrisome, at least acutely, syndrome, because these patients will often present with some mild renal insufficiency, a more active urinary sediment, hypertension. And then the proteinuria in nephritic, in the acute glomerulonephritis, tends to be subnephrotic, but occasionally it can be nephrotic. And this is where we would consider causes of acute glomerulonephritis. And they can be thought about as rapidly progressive patterns of injury, as anti-GBM disease or so-called good pastures, often associated with a pulmonary component. Then there are the angiitis, the ANCA-associated vasculitis, anti-neutrophil cytoplasmic antibody, polyarteritis nodosa, and Wegener's granulomatosis. They can also be seen as part of an immune complex picture with activation of the complement system, either in a post-infectious cause associated with autoimmune disease or an association with cryoglobulins. And we can use the complement to help think about these even before we do the biopsy. But ultimately, these patients are almost certainly going to end up getting kidney biopsied. IgA nephropathy and Henoch-Schönlein purpura, of which IgA is a component of, associated with cutaneous vasculitis and abdominal pain, typically has normal complement levels. And we can see this picture of a nephritic picture of hypertension and decline in renal function and edema in the absence of an immune process, but through an endothelial injury that may be seen with hemolytic uremic syndrome, TTP, malignant hypertension, scleroderma crisis. Just some pictures to show you how these would look at the level of kidney biopsy. Nice normal glomerulus with open capillary loops. This is a rapidly progressive glomerulonephritis where the capillary loops are virtually obliterated and being compressed by this crescent, which is inflammation in Bowman's space that's characteristic of these RPGN pictures. And then the membranous proliferative pattern where there's duplication of basement membrane, increased cellular infiltrate, and glomerular damage through a more necrotizing focal process. And then finally, a thrombotic microangiopathy, which does not have cellular components, but due to endothelial injury and platelet plugging and microthrombi, leads to occlusion of these capillary loops. Okay, so quickly walk through a summary of proteinuria and hematuria, and then we'll conclude. So how do you approach the patient with proteinuria? This is a summary of what we've talked about. First, we're going to confirm it, exclude transient proteinuria orthostatic. We're going to do a 24-hour collection, or I would argue you can even start with the protein-creatinine ratio and subdivide into subnephrotic or nephrotic. In nephrotic-range proteinuria, you're going to think about those glomerular diseases that we talked about, some of which may overlap with nephritic picture, some of which are predominantly nephrotic causing, such as FSGS and minimal change disease and membranous. If the proteinuria is less than 3.5 grams, you really want to know what's in that urine. Are these dysmorphic red cells? Are there red cell casts? Is renal function normal? What is the number for the proteinuria, and what other clues are there to systemic disease? If these are present, then we are going to be really worried, and we're going to end up on this pathway worrying about a nephritic picture and a more intense workup for glomerular disease, again culminating with kidney biopsy. And if you have subnephrotic range proteinuria and inactive sediment, little or no renal function, we want to rule out myeloma and consider the chronic causes of kidney disease, particularly diabetic and hypertensive nephropathy. Okay, same kind of review for hematuria. Again, if there's proteinuria present, dysmorphic red cells or casts, we're going to be worried about a nephronal or renal origin as opposed to urologic origin. So we're going to go down this pathway of looking for those diseases that were listed that can cause this particular picture. So rule out endocarditis and other post-infectious, antistreptolysin O, vasculitis, ANCA titers, complement levels, ANA, and look for some of the more common viral infections that can cause these kidney diseases, particularly Hep C, B, et cetera. And they'll likely end up with a biopsy. If there is not signs of proteinuria and dysmorphic cells, we're probably talking about something more benign and more urologic in origin. You're going to want to rule out whether there's a urinary tract infection, or rarely you might worry about a drug-induced reaction like interstitial nephritis, but very often that will be associated with some proteinuria and some dysmorphic cells. If this is absent, we're going to be going down a urologic evaluation and I would argue that these would be done in parallel with renal imaging. In the real world, most people would get imaged here, although it's useful to think about urine cytology as an adjunct to ruling out malignancy. Again, the 24-hour calcium being associated with hematuria. And then sickle cell patients, for a variety of reasons, can end up with hematuria, and a hemoglobin electrophoresis in the right patient population may be indicated. And then whether this is positive or negative, we'll often end up with our urology colleagues helping us either with a cystoscopy or other imaging. Okay, back to our case. So this particular gentleman had been exposed to an NSAID, and amongst the many things I told you in the last 30 minutes is that NSAIDs can be associated with the nephrotic syndrome. This gentleman definitely had the classic findings of the nephrotic syndrome: preserved GFR, heavy proteinuria, low albumin, and the nephrotic syndrome picture that when we biopsy these patients could be minimal change disease, or it could be membranous, a bit less commonly, but I didn't give you membranous as a choice, so this would be the most common or the most likely reason that he would have had nephrotic syndrome. And then there's one other quick case in here that I'll just go through very quickly. 37-year-old attorney of Chinese descent presents with gross hematuria that's resolved. He had a moderately severe diarrheal illness a few days ago, but no other systemic symptoms. Unremarkable past medical history. No NSAIDs in this case. Fairly healthy appearing, borderline blood pressure, but no other positive findings. He has a creatinine of 1.1 with an estimated GFR that's about 55. He has a urinalysis that shows too numerous to count red cells, many of which are dysmorphic, and his urine protein to creatinine ratio is 2 with a workup that's pending. And the question is, what would be the most appropriate steps in managing this patient? So remember, his acute illness has resolved, his renal function is near his baseline. So would you admit him for urgent biopsy and pulse steroids, await for these serologies and admit for biopsy if positive? Would you start an ACE or ARB and repeat the labs in a couple of weeks, obtain a renal CT scan and send him to urology, or obtain a 24-hour urine for calcium excretion? And the answer to this question is that this is classic IgA nephropathy. Gross hematuria occurring after a mucosal infection, urine sediment that's typical for it. And most nephrologists, myself included, do not biopsy these patients. And we can talk about the specific treatment for IgA, but it's really not an emergent process. So what you would do is certainly monitor him closely and treat proteinuria and be on the lookout for chronic kidney disease as well as flare of the IgA from recurrent infection.